Hi, I'm Dr. Renee Miller. I'm delighted to have been asked to be the clinical advisor on the Rural Health Connect Bereavement Support Program for perinatal loss in higher risk communities. I'm the founder and the principal clinical psychologist of the Antenatal and Postnatal Psychology Network and the Perinatal Loss Centre in Melbourne. I've been working in the field of perinatal mental health and perinatal grief and loss for over 20 years now. During this time, I have seen clients who've experienced many different losses, from the loss of an embryo in assisted reproduction through various stages of pregnancy, as well as neonatal and infant loss, and in fact, the later loss of a child. I've seen many clients who've been confronted by diagnoses of fetal anomalies and decisions about terminating or continuing with a pregnancy when these anomalies have been diagnosed. Every client's experience and grief journey has been different. And from every client, I have learnt something that has contributed to my absolute belief in the human capacity for growth. Sitting in the devastation and depths of despair, and then being with a client over time and seeing how they can grow and where they can get to has been really quite humbling. So welcome to this training module, which is hopefully going to add further understanding to your previous training in perinatal loss, especially around the specific populations that this program is here to support. It's wonderful that you've signed up to be part of this program. Just being able to provide a community service, especially in addition to private practice, this should be so rewarding and enriching. So well done for being a part of this. In the training that you've done so far, you should be informed about types of perinatal loss, symptoms of grief, typical grief, theories of grief and loss, attachment theory and attachment styles in loss, the biopsychosocial model of perinatal mental health, incorporating grief, depression, anxiety, psychosis, complicated grief and trauma. This is just grounding sort of stuff. Don't let this put you off. Pregnancy and birth after loss, parenting after loss, pregnancy decision-making when a fetal diagnosis has been made, and also how different therapy approaches can apply to the grief and loss work that you do. This training module should help you to work in a culturally safe way. As a psychologist generally, you should be trauma-informed, adept at risk assessment, and be thinking about the multiple layers of loss and trauma people might bring to their experience of perinatal loss. Of course, the more you learn about different cultures, the more you'll know, and that's great. Information is knowledge, and knowledge is wonderful. But the individual client holds the information that you really need to know, to attend to explore, to incorporate, and to help them to make sense of things. So, I hope that really helps to guide your work in this area. You just don't need to know everything about every culture. How people grieve differs between individuals, just as it differs between and within religions and cultures. There is no right or wrong way to grieve. The loss of a baby carries a deep existential anguish, and we need to align ourselves to that anguish in terms of what it means for the person and where they're at in their lives. Gestation is less important than the attachment the parent has formed with the baby. So don't get caught up in thinking that, oh, this would be a worse grief because it's a later gestation than an earlier grief. However, we do know that attachment to the baby is what forms the way in which a person experiences their loss. If no attachment was formed with the baby, then they may not grieve as much as if they had formed an attachment with the baby. along the lines of, attaching to the baby is that parents' attachment styles contribute to their experiences of grief. Just very briefly, attachment theory informs how we understand and work with bereaved parents. When it comes to perinatal loss, attachment comes to light in terms of their attachment to the baby that they've lost, their attachment styles and their adaptation to loss, how they experience their emotions, parents' attachment styles, and the ways in which they go about eliciting support from others after a loss. How do they relate to others? How do they experience security in relationships? Who can they trust? All this is informed by, their past and their attachment history. Parents' attachment styles and their future attachments to subsequent children, if you're working with parenting after loss. There is a contribution there in terms of the parent's attachment style. Of course, attachment is formed early in relationships with parents and community. Parents are affected by intergenerational trauma and communities are affected by collective trauma. Consider these layers in the work that you do in this program. The key considerations for working with people who've experienced perinatal loss. Individual people experience loss differently. I mean, really, that needs to be your mantra. The key in supporting bereaved families is to stay client-centered. Who is this person sitting in front of you? How have they experienced their loss? What did they go through physically, emotionally, support-wise? Was there pain? What happened in the moments of the loss? What do they bring to the experience of loss? What do they bring from their past? What have they been through in their lives? What is the landscape of loss for them? What other losses have they experienced? How does their religion or culture inform their experience? How does it help or hinder their experience of loss and mourning? What did the baby mean to them? What did the baby mean in their family, in their social group, in their community? What does the loss mean in their family, their social group, and their community? What support does the individual have? Is their community supportive, and how can you help them to draw on this support? What's the client's narrative around the loss, around the self, around what are their cultural narratives? So how can we best support bereaved parents? Recognize that grief is a process. It's a process that unfolds over time in different ways, at different rates. Again, everyone experiences grief as an individual. Follow the client's lead. Don't make assumptions. Continually seek to understand the individual and to understand their feelings, their thoughts, what they're bringing each time they see you. Be informed about culture, as I said before, but inquire rather than assume. Stay client-centered. Sit alongside the intensity of the emotions. Be a container to hold the client in their grief. If people ask for suggestions about how to mourn, help them to find information from their community elders, their priest, whoever is relevant and important to them. Or you can share, if it's appropriate, some of the rituals you've observed other people do. This can be a process of exploring what feels meaningful to your clients within their personal and social frameworks. But really, above everything, your care, your warmth, calm, kindness, validation, and reflection will keep you client-centered and keep the relationship safe for your client to evolve through their grief. The biggest challenges people face in losing a baby, there are many and varied challenges, as you will discover in working with different people. But some of the themes are, feeling isolated and alone, feeling that people in their lives don't really get the profound nature of their loss, that people can see it as a pregnancy loss rather than the loss of a baby where a relationship and a bond has been formed and that baby was very real, a very real part of the person's body, their imagined future, their new parental self. In many ways, the loss of a baby is the loss of self and the loss of one's existential path that they were on. The biggest challenges therapists face in working with perinatal loss, I think, is, weighing up risk when people can say they want to die to be with their baby. This requires astute risk assessment while acknowledging and validating that extreme pain that they feel and that protectiveness of wanting to look out for their baby, be with their baby. So I guess the work we're doing is to help them to integrate that baby and be with their baby inside of themselves or on the land or within their community, whatever it is that feels right for them. Other challenges, getting caught up in thinking that you need to fix or provide an intervention, your own fertility and pregnancy journey that might, be triggered or get in the way. Taking on the depths of a person's grief and carrying it, after a session. Of course, this is a challenge that we're all faced with as therapists. So hopefully you have ways of managing this. Psychologists, make sure that you seek supervision and make use of the collegial support available in this program. Be mindful of how much you take on. Implement your own self-care strategies, just like you might be suggesting to your clients. Remember, ultimately, you are your client's soft place to land. Ultimately, at the, kind of across all of this work is just believe in the human capacity for growth, especially through the safe and healing relationship that your client is potentially going to have with you.